Welcome to NSG 323, Study Session 7, Uterine Fibroid. Introduction. Uterine fibroids are growth of the uterus that are non-cancerous which appear during the years of childbearing in women, also called leiomyoma or myomas. Uterine fibroids are not related to an increased risk of uterine cancer and most likely never develop into cancer. Uterine fibroids develop when a single cell from the smooth muscular tissue of the uterus, myometrium, divides repeatedly. This creates a firm, rubbery mass distinct from nearby tissue. The growth patterns of uterine fibroids differ and they may grow slowly or rapidly, or they may remain the same size. Some fibroids go through growth spurts and some may shrink on their own. Many fibroids that have been present during pregnancy shrink or disappear after pregnancy as the uterus goes back to a normal size. Fibroids vary in size from sizes unnoticeable by the human eyes to huge masses that can enlarge the uterus. There are extreme cases of fibroids expanding the uterus so much that it reaches the rib cage. As many as 3 out of 4 women have uterine fibroids sometime during their lives, but most are unaware of them because they often cause no symptoms. Your doctor may discover fibroids incidentally during a pelvic exam or prenatal ultrasound. Learning outcome. At the end of the study session, you will be able to define the term uterine fibroid, list the classification of fibroids by location, describe the origin of extrauterine fibroids, identify the signs and symptoms of uterine fibroid. Definition of uterine fibroid. A uterine fibroid is a leiomyoma, benign tumor from smooth muscle tissue that originates from the smooth muscle layer myometrium of the uterus. Fibroids are often multiple, and if the uterus contains too many leiomyoma to count, it is referred to as diffuse uterine leiomyomatosis. Uterine fibroids are growth of the uterus that are non-cancerous, which appear during the years of childbearing in women. The appearance of prominent nucleoli with perinucleolar halos should alert the pathologist to investigate the possibility of the extremely rare hereditary leiomyomatosis and renal cell cancer syndrome. The malignant version of a fibroid is extremely uncommon and termed a leiomyosarcoma. Other common names are uterine leiomyoma, myoma, fibromyoma, fibroleiomyoma. Fibroids are the most common benign tumors in females and typically found during the middle and later reproductive years. While most fibroids are asymptomatic, they can grow and cause heavy and painful menstruation, painful sexual intercourse, and urinary frequency and urgency. Some fibroids may interfere with pregnancy, although this appears to be very rare. Pathophysiology. Leiomyomata grossly appear as round, well circumscribed, but not encapsulated, solid nodules that are white or tan, and show word appearance on histological section. The size varies from microscope to lesions of considerable size. Typically, lesions the size of a grapefruit or bigger are felt by the patient herself through the abdominal wall. Microscopically, tumor cells resemble normal cells, elongated, spindle-shaped with a cigar-shaped nucleus. and form bundles with different directions, walled. These cells are uniform in size and shape, with scarce mitosis. There are three benign variants: bizarre, atypical, cellular, and mitotically active. Location and classification. Schematic drawing of various types of uterine fibroids. A. Subserosal fibroids. B. Intramural fibroids. C. Submucosal fibroid. D. Pedunculated submucosal fibroid. E. Fibroid in staternascendi. F. Fibroid of the broad ligament. Growth and location are the main factors that determine if a fibroid leads to symptoms and problems. A small lesion can be symptomatic if located within the uterine cavity, while a large lesion on the outside of the uterus may go unnoticed. Classification of fibroids according to location. Different locations are classified as follows. 1. Intramural fibroids are located within the wall of the uterus and are the most common type. Unless large, they may be asymptomatic. Intramural fibroids begin as small nodules in the muscular wall of the uterus. With time, intramural fibroids may expand inwards, causing distortion and elongation of the uterine cavity. 2. Subserosal fibroids are located underneath the mucosal peritoneal surface of the uterus and can become very large. They can also grow out in papillary manner to become pedunculated fibroids. This pedunculated growth can actually detach from the uterus to become a parasitic leiomyoma. 3. Submucosal fibroids are located in the muscle beneath the endometrium of the uterus and distort the uterine cavity. Even small lesions in this location may lead to bleeding and infertility. A pedunculated lesion within the cavity is termed an intracavitary fibroid and can be passed through the cervix. 4. Cervical fibroids are located in the wall of the cervix, neck of the uterus. Rarely, fibroids are found in the supporting structures, round ligament, broad ligament, or uterosacral ligament of the uterus that also contains smooth muscle tissue. 5. Fibroids may be single or multiple. Most fibroids start in an intramural location, that is the layer of the muscle of the uterus. With further growth, some lesions may develop towards the outside of the uterus or towards the internal cavity. Secondary changes that may develop within fibroids are hemorrhage, necrosis, calcification, and cystic changes. Extrauterine fibroids of uterine origin. Metastatic fibroids. Fibroids of uterine origin located in other parts of the body, sometimes also called parasitic myomas, have been historically extremely rare, but are now diagnosed with increasing frequency. They may be related or identical to metastasizing leiomyoma. They are in most cases still hormone dependent, but may cause life-threatening complications when they appear in distant organs. Some sources suggest that a substantial share of these cases may be late complications of surgeries such as myomectomy or hysterectomy. Particularly, laparoscopic myomectomy using a mutilator has been associated with a substantially increased risk of this complication. Etiology. Fibroids are monocional tumors, and approximately 40 to 50% show karyotypical detectable chromosomal abnormalities. When multiple fibroids are present, they frequently have unrelated genetic defects. Exact etiology is not clearly understood, but the current working hypothesis is that genetic predispositions, prenatal hormone exposure, and the effects of hormones, growth factors, and secnoestrogens cause fibroid growth. Known risk factors are African descent, null parity, obesity, polycystic ovary syndrome, diabetes, and hypertension. Fibroid growth is strongly dependent on estrogen and progesterone. Although both estrogen and progesterone are usually regarded as growth promoting, they will also cause growth restriction in some circumstances. Paradoxically, fibroids rarely grow during pregnancy, despite very high steroid hormone levels, and pregnancy appears to exert a certain protective effect. This protective effect might be partially mediated by an interaction between estrogen and the oxytocin receptor. Diagnosis. While a bimanual examination typically can identify the presence of larger fibroids, gynecologic ultrasonography ultrasound has evolved as the standard tool to evaluate the uterus for fibroids. Sonography will depict the fibroids as focal masses with a heterogeneous texture, which usually cause shadowing of the ultrasound beam. The location can be determined and dimensions of the lesion measured. Also, magnetic resonance imaging (MRI) can be used to define the depiction of the size and location of the fibroids within the uterus. Imaging modalities cannot clearly distinguish between the benign uterine leiomyoma and the malignant uterine leiomyosarcoma. However, the latter is quite rare. Fast growth or unexpected growth, such as enlargement of a lesion after menopause, raise the level of suspicion that the lesion might be a sarcoma. Also, with advanced malignant lesions, there may be evidence of local invasion. A more recent study has suggested that diagnostic capabilities using MRI have improved the ability to detect sarcomatous lesions. Biopsy is rarely performed, and if performed, is rarely diagnostic. Should there be an uncertain diagnosis after ultrasound and MRI imaging, surgery is generally indicated. Signs and symptoms. Fibroids, particularly when small, may be entirely asymptomatic. Symptoms depend on the location of the lesion and its size. Important symptoms include abnormal gynecologic hemorrhage, heavy or painful periods, abdominal discomfort or bloating, painful defecation, backache, urinary frequency or retention, and in some cases, infertility. There may also be pain during intercourse, depending on the location of the fibroid. During pregnancy, they may also be cause of miscarriage, bleeding, premature labor, or interference with the position of the fetus. While fibroids are common, they are not a typical cause for infertility, accounting for about 3% of reasons why a woman may not have a child. Typically, in such cases, a fibroid is located in a submucosal position, and it is thought that this location may interfere with the function of the lining and the ability of the embryo to implant. Also, larger fibroids may distort or block the fallopian tubes. Uterine fibroid symptoms. Most fibroids do not cause symptoms. Only 10 to 20% of women who have fibroids require treatment, depending on size, location, and number of fibroids. They may cause heavy, prolonged menstrual periods and unusual monthly bleeding, sometimes with clots. This can lead to anemia, pelvic pain and pressure, pain in the back and legs, pain during sexual intercourse, bladder pressure leading to a frequent urge to urinate, pressure on the bowel leading to constipation and bloating, abnormally enlarged abdomen. Symptomatic uterine fibroids can be treated by a number of medications are in use to control symptoms caused by fibroids. NSAIDs can be used to reduce painful menses. Oral contraceptive pills are prescribed to reduce uterine bleeding and cramps. Anemia may have to be treated with iron supplementation. Levonorgestrel intrauterine devices are highly effective in limiting menstrual blood flow and improving other symptoms. Side effects are typically very moderate because the levonorgestrel, a progestin, is released in low concentration locally. There is now substantial evidence that levonorgestrel IUDs provide good symptomatic relief for women with fibroids. Medication to control symptoms. Medication aimed at shrinking tumors. Ultrasound fibroid destruction, mammectomy or radiofrequency ablation, hysterectomy, uterine artery embolization. Medications. While most levonorgestrel IUD studies concentrated on treatment of women without fibroids, a few reported very good results specifically for women with fibroids, including a substantial regression of fibroids. Danazol is an effective treatment to shrink fibroids and control symptoms. Its use is limited by unpleasant side effects. Mechanism of action is thought to be antiestrogenic effects. Recent experience indicates that safety and side effect profile can be improved by more cautious dosing. Doxynex is a moderate and well-tolerated doses has been shown in 2 studies to shrink fibroids effectively. Mechanism of action is unclear. Gonadotrophin releasing hormone analogs cause temporary regression of fibroids by decreasing estrogen levels. Because of the limitations and side effects of this medication, it is rarely recommended, other than for preoperative use, to shrink the size of the fibroids and uterus before surgery. It is typically used for a maximum of 6 months or less because after longer use, they could cause osteoporosis and other typically postmenopausal complications. The main side effects are transient postmenopausal symptoms. In many cases, the fibroids will regrow after cessation of treatment. However, significant benefit may persist for much longer in some cases. Several variations are possible, such as GnRH agonist with add-back regimens intended to decrease the adverse effects of estrogen deficiency. Several add-back regimens are possible: Tibolone, raloxifene, progestogens alone, oestrogen alone, and combined estrogens and progestogens. Medication. 1. Surgeries. Myomectomy is a surgery to remove one or more fibroids. It is usually recommended when more conservative treatment options fail for women who want fertility-preserving surgery or who want to retain the uterus. There are 3 types of myomectomy. 2. Hysterectomy. Hysterectomy was the classical method of treating fibroids, although it is now recommended only as last option. Fibroids are still the leading cause of hysterectomies in the US. Magnetic resonance guided focused ultrasound is a non-invasive intervention requiring no incision that uses high-intensity focused ultrasound waves to destroy tissue in combination with magnetic resonance imaging (MRI), which guides and monitors the treatment. During the procedure, delivery of focused ultrasound energy is guided and controlled using MR thermal imaging. Patients who have symptomatic fibroids, who desire a non-invasive treatment option, and who do not have contradictions for MRI are candidates for MRG-FUS. About 60% of patients qualify. It is an outpatient procedure and takes 1 to 3 hours depending on the size of the fibroid. It is safe and about 75% effective. Symptomatic improvement is sustained for 2+ years. 3. Endometrial ablation. Endometrial ablation can be used if the fibroids are only within the uterus and not intramural and relatively small. High failure and recurrence rates are expected in the presence of larger or intramural fibroids. Magnetic resonance guided focused ultrasound. Epidemiology. Picked leiomyomata in an obese woman. Leiomyomata are more common in obese women. Fibroids are dependent on estrogen and progesterone to grow and therefore relevant only during the reproductive years. They are expected to shrink after menopause. Globally, approximately 235 million people are affected with uterine fibroids as of 2010. 6.6% of females, about 20 to 40% of women will be diagnosed with leiomyoma at some point in their life, but only a fraction of those will cause problems or require treatment. Genetic associations. An association with fatty acid synthase has been reported. Prognosis and metastasis. Prognosis. About 1 out of 1,000 lesions is or become malignant, typically as a leiomyosarcoma on histology. A sign that a lesion may be malignant is growth after menopause. There is no consensus among pathologists regarding the transformation of leiomyoma into a sarcoma. Metastasis. There are a number of rare conditions in which fibroids metastasize. They still grow in a benign fashion, but can be dangerous depending on their location. In leiomyoma with vascular invasion, an ordinary appearing fibroid invades into a vessel, but there is no risk of recurrence. In intravenous leiomyomatosis, leiomyomata grow in veins with uterine fibroids as their source. Cardiac involvement can be fatal. In benign metastasizing leiomyoma, Leiomyomata grow in more distant sites, such as the lungs and lymph nodes. The source is not entirely clear. Pulmonary involvement can be fatal. In disseminated intraperitoneal leiomyomatosis, leiomyomata grow diffusely on the peritoneal and omental surfaces with uterine fibroids as their source. This can simulate a malignant tumor but behaves benignly. Summary: in this study session, you have learned the definition of uterine fibroid. You have listed the classification of fibroids by location, and you are able to describe the origin of extrauterine fibroids and also identify the signs and symptoms of uterine fibroids. End of study session 7. Thanks for listening.